So I was discussing about the um, endometrial hyperplasia with it without atypia. So in this, I was discussing that we will call the patient, and we will after 6 months after the treatment LNGIUS, and we will treat the patient, have the endometrial surveillance. If we get two negative biopsy, we will discharge the patient. But if patient is having BMI more than 35, or patient is having has been treated for the progestogen for 6 months, oral progestogen, she will be monitored throughout life by annual endometrial sampling. So normally hysterectomy in endometrial hyperplasia without atypia is not the first line treatment. So hysterectomy is indicated in women not wanting to preserve their fertility. When your patient knows that there is a treatment of observation, and there is we can observe, we can treat with LNGIUS, or we can treat with oral progestogen, but she does not want. We can these are the women which are having option of hysterectomy if progression to atypical hyperplasia occur during follow-up. So after 6 months, you call the patient, then a biopsy shows that it's endometrial hyperplasia with atypia. You will do hysterectomy. There's no histological regression of hyperplasia despite 12 months of treatment. And historical, you are unable to find any histological regression. There's a relapse of endometrial hyperplasia after completing progestogen treatment. Once 1 year, you have discharge the patient after 1 year, but again she comes after 1 or 2 years that she's having bleeding, and you see that she's again having endometrial hyperplasia without atypia even, then you will do the hysterectomy this time. There's a persistence of bleeding symptoms, and the woman declines to undergo endometrial surveillance or comply with the medical treatment. So postmenopausal women, whenever you offer the hysterectomy to the patient on the basis of endometrial hyperplasia without atypia, so the main treatment is you want to remove the uterus. So regarding ovary, whether you want to remove or not, it depends upon the circumstances. Because if the patient is postmenopausal, so there is no point of retaining ovaries. So then you will offer the patient bilateral salpingo-oophorectomy together with the total hysterectomy. For premenopausal women, the decision to remove the ovaries should be individualized. However, bilateral salpingectomy should be considered, as this may reduce the risk of future ovarian malignancy. We can discuss whether we want to retain the ovary or not, but we will remove the tubes in all cases. A laparoscopic approach to total hysterectomy is preferable to an abdominal approach. So this is the whole case of endometrial hyperplasia without atypia. Now, again, I'm giving another example of, this is different patient from the previous. This patient is also having, we came with the abnormal uterine bleeding. We take history, did the examination, and speculum examination, and we ruled out all the causes of bleeding, infection, trauma, cervical bleeding, and we think that she's having bleeding coming from uterus, and we did the TVS. On the TVS, we have seen that there's endometrial thickening, and we take an outpatient biopsy. So on the outpatient biopsy, we saw that patient is having atypical hyperplasia. So the atypical hyperplasia, there are certain things we should know, that the cumulative risk of cancer is in 4 years was 8%, which increased to 12.4% after 9 years, and to 27.5% after 19 years. So it's a progressive. It's much more than in the endometrial hyperplasia without atypia. There is a 5% risk of endometrial cancer in 20 years. So in 19 years, it's having 27.5%. And along with atypical hyperplasia, we should know that we will give the only option to the patient that she should have total hysterectomy because of the risk of underlying malignancy, 43%, or progression to cancer. There are chances that cancer is there because when they did the studies on this patient where endometrial hyperplasia with the atypia, their patient was having, they did a hysterectomy. On the hysterectomy sample, they have seen that there is already endometrial cancer was there in 43% of cases. A laparoscopic approach to total hysterectomy is preferred to an abdominal approach. Postmenopausal women with atypical hyperplasia should be offered bilateral salpingo-oophorectomy together with the total hysterectomy. So, for premenopausal women, the decision to remove the ovaries should be individualized. However, bilateral salpingectomy should be considered, as this may reduce the risk of future ovarian malignancy. Endometrial ablation is not recommended because complete or persistent endometrial destruction. Endometrial ablation is not recommended either neither in atypical endometrial hyperplasia or without atypia, because with endometrial ablation there is a destruction of the endometrium and their adhesion formation, which make it difficult to take the sample in the follow-up endometrial surveillance. So there is no benefit from intraoperative frozen section analysis of the endometrium or routine lymphadenectomy. So now there are women. This is a simple case of endometrial hyperplasia with atypia, that we will do the hysterectomy and we will do the consult the patient that there are chances that cancer is already there. So now there is next stage discussion, that the women who wish to retain fertility. This is very interesting topic, and they always ask question from this part of the guideline. So I will discuss this guideline in detail. So the women who wish to retain fertility, this is the woman who is having endometrial hyperplasia with atypia. So ideal treatment is she should have hysterectomy, but now she want to retain the fertility. So in this woman, counseling is very, very important. So we will tell the patient that what she is asking for. Women wishing to retain their fertility should be consulted about risk of underlying malignancy, that she is having cancer, maybe she is having cancer now, and subsequent progression to endometrial cancer. So if she says, no, I still want the pregnancy. So it is very delicate time that we want to make sure, because she tells us her desire. She is not a doctor. We are doctors. So we will make sure that she is taking the right decision. So she expressed her desire. So we will now completely screen the patient, because we know that in 43% cases of endometrial hyperplasia with atypia, there is cancer. So we want to make sure that she's not having cancer right now. So we will do the pre-treatment investigation. So here there is a role of MRI and their tumor markers. So we should aim to rule out invasive endometrial cancer or coexisting ovarian cancer. As I have told you that granulosa cell tumor of the ovary can produce a large number of estrogen, and that will cause endometrial hyperplasia. The main problem is not in the endometrium. There is problem in the ovary. So we want in this patient, because we don't want to we want to make sure that patient is not having endometrial cancer, not having ovarian cancer. So we need careful counseling of the risk involved with this option: coexistence or persistent progression to endometrial cancer, coexistent ovarian cancer, and metastatic disease and death. The risk of coexisting ovarian cancer was up to 4%. The risk of progression to higher than stage 1 endometrial cancer was about 2%, and the risk of metastatic disease and death was about 0.5%. So after we have discussed all these things with the patient, we will tell the patient, because these are the point which I did not get while reading the guideline on first time. So these are very important for me, because I learned it after my teacher pointed out to me that these are the things. So on the histology, we will do, already we have done the endometrial sampling from the endometrial hyperplasia, because this question already also they make station part 3 station from this scenario, because patient want to conceive. So patient have endometrial, well, they will give you the patient is having endometrial hyperplasia with atypia, and when you go inside the patient, then patient say that I want to retain my uterus. So you will tell her that we will go for hysteroscopy again. She will ask you why you want to go for hysteroscopy when you already know that I am having endometrial hyperplasia with atypia, because there is a reason for that. You will tell her that we have seen we have taken that sample from outpatient biopsy. So we want to see the all sides of the uterus. We want to take sample. We want to make sure, because there is no coexisting cancer, because in 43% of atypical hyperplasia there is cancer. We want to make sure there is no cancer. So we will do the hysteroscopic examination and we will see thoroughly the endometrium. Then we will do the all the serum markers, CA125, inhibin A, estriol, and then we do MRI to see whether cancer is more than stage 1 endometrial cancer and it's involving the uterus. If on TVS they see there is some cyst in the ovary, even small or large, whatever, small cyst, then you will do CT scan as well. So women who want to wish for retain fertility, alongside those investigation which are routine for all patient of endometrial hyperplasia, before going for fertility treatment, she will go through hysteroscopy, MRI, and TVS she has already we have done, and we will do the serum one CA125 inhibin A and estriol. If there is any cyst on TVS, we will do the CT scan as well. It is essential that initial diagnosis is confirmed on formal hysteroscopy to minimize the chance of missing cancer. Women with endometrial hyperplasia who wish to conceive should be referred to fertility specialist to discuss the options for attempting conception, further assessment, and appropriate treatment. So we will tell patient we will do all these investigation and we will discuss your case in the multidisciplinary team. MDT is very important in making decision for this patient whether we should leave this patient for the for fertility treatment or we should do hysterectomy. So all these investigation come normal and we will discuss in the MDT multidisciplinary team, and then we will make a decision that yes, we can give this patient the trial of conception. So we will then we will discuss the patient. We will not leave this patient to for the natural conception because after doing investigation, we made sure this is only endometrial hyperplasia without atypia. Now we want to treat this patient. Treatment is the same. First is the LNG-IUS and then progestogen. But only difference is we will in the atypic without atypia we did the follow up after 6 months. Here we do the follow up after 3 months. So once we see that we get one sample of endometrial surveillance is showing regression, then we can refer the patient for the fertility specialist to the fertility specialist to discuss the option for attempting conception and further assessment and appropriate management. We will not leave this patient for natural conception because we don't want to waste the time first because once we have completed the treatment and we will leave the patient for natural conception, so there is a time where no progestogen is given to the patient. So this time is risky. And secondly, when there is endometrial hyperplasia, there is a chances that patient may not achieve clinical pregnancy. She may have a miscarriage. So we will send this patient for fertility specialist, and then we will we can opt for assisted reproduction as well in this patient. First line treatment with LNG-IUS should be recommended with oral progestogen or as a second best alternative. Disease regression should be achieved on at least one endometrial sample before women attempt to conceive. Assisted reproduction may be considered as the live birth rate is higher and it may prevent relapse compared with women who attempt natural conception. Once fertility is no longer required, hysterectomy should be offered in view of high risk of the disease relapse. If fertility sparing therapy fails to induce regression of atypical hyperplasia by 12 months, if you have waited for 12 months and still you are not able to achieve regression, or there is evidence of progression to cancer, women should be strongly recommended to undergo hysterectomy. Okay, routine endometrial surveillance should include endometrial biopsy. Review interval should be every 3 months until 2 consecutive negative biopsies are obtained. So in asymptomatic women with a uterus and evidence of histological disease regression based on a minimum of 2 consecutive negative endometrial biopsy. Long-term follow-up with endometrial biopsy every 6 to 12 months is recommended until a hysterectomy is performed. So we have received 2 negative samples. And then we will follow this patient up until hysterectomy is performed, and we will follow this patient for 6 to 12 monthly endometrial sampling. So this is the management of the patient who is wishing to retain the fertility.